We'll start the lecture on the viruses and antiviral agents. A virus is nothing but a genome that is either RNA or DNA that has a protein coat around it. So it is a particle that contains a genome surrounded by a protein coat. And so the debate is still on whether a virus is actually a living organism or just a particle. The preponderance of the evidence suggests that it is not a living organism. We know that it can do damage to host cells and cause some severe infectious diseases. A virus cannot exist without a living tissue. So it requires a living tissue for it to continue to exist. Okay. So that's a fact. But whether it's a living thing or not, that's still debatable. And so you can divide the viruses into two major groups, those that are DNA containing and those that are RNA containing. So it either contains DNA or it contains an RNA. That's its genome. And that's what you have in that chart that we gave you. It's also in your handout on Blackboard, but I just brought this so you can follow as we go through. And so you see there are some that are DNA containing, those are the ones listed at the top. The first one you see there is your adenoviruses. There are many, hundreds of adenoviruses. Your common cold virus is a member of that group. It's an adenovirus. And then next to that you have the herpes group of viruses. When people hear of the word herpes, they always think that it is just herpes simplex. But as you see on that chart, your HSV1 is a member of that herpes group. So HSV1, that is herpes simplex virus. Okay. HSV1, HSV2, they're both members of the herpes family. Your CMV, that is cytomegalovirus. Your EBV, Epstein-Barr virus. Those are all members of your herpes family. And when you have VZV, the varicella zoster virus is actually a member of the herpes family. And then the herpes zoster virus is also a member of that herpes family. And you have one that is called, human herpes virus 8 and human herpes virus 6. And so these are all members of the herpes family. HSV1 and HSV2 we know will cause your genital herpes, and would also cause that oral, or what you call cold sores. Okay. Both of them, that is HSV1 and HSV2, both of them can cause both genital and oral. Okay, people just think that Only HSV1 causes the cold sore, and HSV2 causes the genital. No, both of them can cause both conditions. It's just that your HSV1 causes more of the cold sores than genital herpes, and HSV2 causes more of the genital herpes than it does the oral lesions. Cytomegalovirus, for the most part, affects the eyes. And you have what you call CMV retinitis. That is the number one cause of blindness in AIDS patients. Remember, we said the second one will be toxoplasmosis. Okay? The number one cause of blindness in AIDS patients is CMV. That causes the retinitis. But of course, it causes other conditions. It can even cause infectious mononucleosis, just to mention another one there. EBV, Epstein-Barr virus, is one of those viruses that can cause cancer. If you look on that chart, you see Burkitt's lymphoma. Burkitt's lymphoma is a type of tumor that can develop into a cancer, and it is caused by Epstein-Barr virus. Epstein-Barr virus can also produce some infectious mononucleosis, and as you probably see that it is also one of your viruses that can cause hepatitis. So it can produce those. VZV is what you very often say is responsible for chicken pox, and HZV, you say that's responsible for shingles. We'll leave it at that, but it's more complicated than that. It's not that clear cut, but okay, we can leave it as such. And as you look through that chart, you will see that it's not only varicella that causes chicken pox. Your pox viruses, if you see at the bottom of the DNA containing ones, pox viruses can also cause your chicken pox. So it's not just your varicella. Human herpes virus 8, that's the causative agent of Kaposi sarcoma. And that is a type of skin cancer that you see in AIDS patients. In fact, it is one of the lesions that you can use to diagnose AIDS. It would appear purplish, like a purple discoloration of the skin, but it is rather pathognomonic of your HIV. So Kaposi has been shown to be caused by that HHV8. HHV6, that is human herpes virus 6, causes what is called roseola infantum. As you see, that is a viral condition that is found in infants. It's usually between the ages of 6 months and 2 years, when they get infected with that HHV6, and it can remain in the child's body actually throughout the rest of their life if they contact that HHV6. So roseola infantum is caused by your HHV6. So that's the herpes family. And if we move on to your papovaviruses, that is the family, okay, you have to break that into three. Okay. Pa is referring to papilloma. And you know your human papillomavirus, HPV, is the one that is responsible for, some cervicitis or your so-called wart, okay, or condylomata acuminata. That would be the technical name for what? And that's actually plural. If it's just one lesion, it will be condyloma acuminum. But if there are many words, that's usually easy to identify or detect because it will look like cauliflower. Wart has a cauliflower appearance, so it's very easy to diagnose. And usually it's caused by your HPV 11 and 16 very often, but you have about 9 strains of your HPV. So that's what the PA is for. And then the PO is polyoma. Polyoma virus, that's the group. An example of the polyoma virus is a virus that is called the JC virus. JC stands for John Cunningham. So it's actually named after somebody. And John Cunningham virus is the one that has been implicated in that leukoencephalopathy, progressive multifocal leukoencephalopathy, PML, very serious condition that affects the brain. You get dementia, you can't think, and it rapidly, the patient rapidly deteriorates. So it's something to always watch out for. So that's your JC, or John Cunningham virus. It's a member of that polyoma virus. And then the vacuolating virus, and that's where you have your simian virus 40. Simian virus 40, another virus that can cause cancer. Okay. It's your simian virus. So papilloma can give you that genital wart, but it can also lead to cervix cancer. Okay, so that would be another example of a virus that can eventually produce cancer. And then the last group among your DNA containing ones will be the pox viruses. Okay. The pox viruses, and that will include your variola virus. The variola virus that we know has been implicated in smallpox. And of course, smallpox has basically been eradicated around the world. But it has a strange and unpleasant history because been tied to the advent of HIV. There's a lot of evidence that shows that when the World Health Organization was talking about eradicating pox virus, that the variola, that was the vaccine that was laden with the HIV. And that HIV is actually a combination of Yersinia virus, which is also one of your pox viruses, and an equine virus. There's a lot of history behind that, but anyway. So it can produce your smallpox, and you say that Yersinia can produce your cowpox. The monkeypox virus will also belong in that group. Monkeypox virus. About 9 months ago, this was supposed to be the next pandemic after COVID-19. It was being pushed as another pandemic, but that push has subsided now. But monkeypox virus belongs to the pox virus family. And it's still around. It's just that it did not reach the pandemic level that was predicted. Yeah. And you see chickenpox there also as one of the conditions that your pox viruses can produce. Chickenpox virus has nothing to do with Kentucky Fried Chicken. Okay, has nothing to do with chicken at all. It is called chickenpox because the lesions, that is the skin lesions, look like chickpeas. That's how they got the name chickenpox. Okay, so it has nothing to do with chicken. Okay, so those are your DNA containing viruses. The RNA containing viruses, the first one you see there will be the arenavirus. Your arenaviruses can cause things like this Lassa fever. So that Lassa fever virus is an arenavirus. Sometimes it is called a swollen baby disease because of the tremendous facial edema that occurs when the patient has that Lassa fever. And LCM is also an arenavirus that can infect humans. And then you go to your orthomyxovirus, which is the one we all know, that's your flu. Influenza type A, type B, there is a type C, but mainly it is a type A that infects humans, and occasionally we also see type B infection. So that would be your orthomyxovirus. And then the para, that is paramyxovirus, that would include your parainfluenza virus. So you can see pulmonary manifestations that would look, like your flu. And then you have the RSV, okay, the respiratory syncytial virus, which used to be just small children infection, or spongival viral infection. But now we know that it is occurring more and more in individuals who are 60 and above, and it's causing a lot of deleterious effects among that population, and that's why we advise them to go and get the vaccine. You know, there's one that's called RSV. That we give, the pharmacy, that helps with the incidence of that respiratory syncytial virus, but it's for people who are 60 and above. Abrasivir is another one. That is also meant for individuals who are 60 and above. Nirsevimab is one that is meant for children or kids who are about 8 months old, all the way to about 5 or 6. But usually, if they're less than 8 months or around 8 months, they can get that nirsevimab. And it is very effective in preventing the RSV in children. There are drugs you can use to actually treat RSV. Palivizumab is one that has been in existence for a long time. It's one that can help. Ribavirin is another drug that can help. I think I put it over here. Ribavirin. That's another drug that can help with that respiratory syncytial virus infection. And in that group, you also have your mumps, so it will be part of the paramyxoviruses. That one can see there. Picornavirus, that will include your rhinoviruses, and it will also include your enteroviruses. And you see under your enteroviruses is where you have polio. So polio virus is an enterovirus, and of course it belongs to the picornavirus family. Okay. And you have the Coxsackie virus. If you go on a ship, what do you call that when you sail out somewhere?
Cruise.
On a cruise, thank you. And you come back all sick, vomiting, nauseated, and all that. It is most likely because you contacted Coxsackie virus. There are usually just 2 of them that cause all these GI-related infections on a cruise ship. It's usually Coxsackie or a rotavirus. Rotavirus is a real virus. It belongs to the real virus group. Okay. And of course, you have the echovirus, which is also a member of your enteroviruses. And if you have an enterovirus infection or just a picornavirus infection, you can always use this drug flecainuril. That's the only use of that drug, flecainuril, is only for picornavirus infections. Okay? And the way it works, it actually lodges nothing is working this morning. It lodges inside a hydrophobic pocket on the membrane of the host cell, such that the picornavirus cannot bind to the cell membrane. And if it cannot bind, then it cannot enter. If it cannot enter the host cell, it cannot produce the infection. Thank you. Okay, so that's how that flecainuril works, and it's just mainly used for picornavirus infections. All right, and then of course you can see your real viruses. And the main one there is the one that I told you will cause that GI infections. The rotavirus causes a lot of GI infections. And then retroviruses. That, of course, is where you have your HIV. It's where you have your HTLV, the human T cell lymphotropic virus, and that group causes a lot of cancer, if you will, or tumors in humans, and like we mentioned, can cause AIDS. Okay. And then you have the group that can cause rabies. So the rabies virus, which you can get from a dog that bites, if the dog is not immunized, if you will, against rabies. So that can produce rabies. And then you have your toga viruses. Togaviridae is actually a large group that your arbovirus belongs to, and your encephalitis virus will be in there, and then your rubella virus. Okay. The rubella virus that causes German measles. Okay, so rubella is different from rubeola. Okay. Rubeola causes your usual type of measles. Rubella causes German measles. Okay. German measles it's better tolerated. In other words, it doesn't cause severe manifestations. It's not as severe as your regular measles. Okay. But unfortunately, if a pregnant patient gets infected with that rubella virus, it can affect the fetus. That's one of the problems with your German measles. Now, there are some Togaviridae members that are not on that list, well, that are important. The virus that causes encephalitis, or maybe we can start with your yellow fever is mentioned here. Okay. Yellow fever virus belongs to that Togaviridae, that is the Toga family, Toga virus family. And we know that your yellow fever can cause, of course, not just fever, but it can cause hemorrhagic fever. Okay. And it is transmitted, of course, by your mosquitoes, especially your Aedes aegypti. Okay. Your dengue fever, or that is caused by the dengue virus, is also one of those members of the Togaviridae, or, well, let me put it this way. The large group is the Togaviridae. That would be the huge family. The arboviruses are members of that big family. Okay? And then the flaviviruses are members of arboviruses. So all this yellow fever, dengue fever can belong into, or can be mentioned or classified as arboviruses, or sometimes they're called filiviruses also. So those would be examples. And the dengue fever is also basically carried by mosquitoes, Aedes. Zika, which we had not too long ago, the Zika virus, also caused by Aedes aegypti, so the same mosquito is what carries those viruses. Okay. And they are all hemorrhagic fever. So you have high fever and you can have hemorrhage. There's one called chikungunya. Chikungunya virus is also one of your arboviruses that can be transmitted by Aedes aegypti, the same mosquito. There are some that are transmitted by Culex mosquito. Okay? For instance, if you look at your St. Louis encephalitis, okay, is caused by the St. Louis encephalitis virus. Okay. That is transmitted by your Culex mosquito. Okay. West Nile encephalitis, or West Nile fever, okay, is also transmitted by your Culex mosquito. The triple E which was affecting a lot of children around Houston for a while. So it's called triple EEE. That was also transmitted by a mosquito, and it's very dramatic in children because not only do they have this high fever and they're coughing and they're disoriented, and then they experience paralysis. And it was occurring in a lot of middle school and elementary school children in Houston. But it is also one of your arboviruses transmitted by another type of mosquito related to the culex. And if you look at your so-called hepatitis viruses, hepatitis B is the only one that is DNA containing. All the others are RNA containing. So your A, C, E, F, G, those are RNA containing. Hepatitis B, as in boy, is the only one that is DNA containing. And then Ebola virus. Ebola virus used to be thought of as a member of the rabies group, but now it's classified as a flavivirus, so it belongs to a different group. Okay. And then, of course, you have your coronaviruses. We know that coronaviruses will be implicated in SARS, severe acute respiratory syndrome, implicated in MERS, Middle East respiratory syndrome, and then your SARS-CoV-2, which is your COVID-19. So those are all coronaviruses. All right. So those are some different groups of your viruses. And all viruses tend to have the same pattern of infectivity. In other words, they seem to follow the same pattern. Their receptors will be different, but the pattern is always something like this. The virus comes close or comes into contact with the host cell, okay? And then it binds to a particular receptor on the host cell. In the case of HIV, it will be CD4 and CD8 proteins. And of course, we know in the case of your COVID-19, it will be the ACE2, angiotensin converting enzyme 2 protein on the cell membrane. So the virus comes to the cell, binds to the receptor, and that's what we will call attachment. So it attaches to the membrane of the host cell. And then it will fuse with the host cell and gain entrance into the cell. And once it gets into the cell, it will remove its coat. And that's what's called uncoating. Okay? In the case of COVID, the host cell actually helps to remove that coat of the virus. Okay? So once you remove the coat, then the genome of the virus, be it DNA or RNA, is released into the host cell. And it will direct the host cell mechanisms to replicate itself, to replicate and reproduce its genome, and then to produce some viral proteins. And when all those are synthesized, then they will be repackaged. In other words, they will come together, that is assembly, they will be repackaged, and so you will have a new virion that is produced, and then that virion would be released from the host cell, or what is commonly called budding out. It is that budding out that destroys the host cell. Okay. So a new virus has now been made, and then it goes to an uninfected cell and carries out its infection the same way. And there is a drug that is called Antivirals that you normally use for cold sores. Cosanol is the generic name. So the way Antivirals works is just to affect the membrane of the unaffected cell, that is the cell that has not yet been infected. So it will modify the membrane of the healthy cells such that they will not permit that new virus to attach to the uninfected cells. So Antivirals is a membrane modulator. That's how it prevents infection of a previously uninfected cell. All right. So everything then from the period of, from the point of attachment all the way to that uncoating of the virus, that is called the early stage of viral infection. Okay. And after the early stage, you will get to the synthetic event. That's when the genome of the virus is being replicated or reproduced. And then you get to the late stage or late phase of viral infection. That includes the assembly, the repackaging, and then the release from the host cell. So you can divide viral infectivity into those three phases. The early phase, the synthetic event phase, and then the late event or late phase of viral infection. And we will start with the early events or early stage of viral infections. So the drugs that are used to handle, or that the drugs that work at the early event phase are the ones we listed here. A couple of them will not fit neatly, but I'll tell you why I have them listed there. Okay, so we've already mentioned Antivirals, which will be one of those that would affect the early stage. Okay, and we mentioned Preconarel. Fostemsavir is a prodrug for tenofovir. but both of them are used clinically. And the mechanism of action for tensoria or first tensoria is that it would bind to glycoprotein 120 on the virus. If you're looking at the HIV and you look at its envelope, the envelope is considered to have GP, that is to be made of glycoprotein 160. Okay? GP 160 will then have two subunits. One is GP 120 and the other is GP 41. If you add that up, it's one more than 160, but that's just the nature of the breakdown. If it's together, it's 160. If it's broken down to subunits, it will be 120 and then 41. Okay, so those are glycoproteins that you will find on the envelope of that, the envelope membrane of that HIV. Okay. So these two agents, FOS as well as tensoria, they would bind to the GP120. And when they bind to that GP120, the GP120 will not be able to attach to the host cell. Okay, so there's no attachment, there's no fusion, there's no entry, there's no uncoating, and so there will be no infection. So that's how they work, and they're used only in the management of HIV today. Okay, so they are inhibitors of the early stages of viral infection. Okay, we would leave this for the time being, and we'll go to amantadine, rimantadine, and aridone. Those three are called the M2 protein channel inhibitors. And the one that is most often used there is amantadine. Okay. Amantadine used to be a very popular drug, Senator, that we use for preventing flu. It was used to prevent flu back in the day, but today it is mainly used for minor or not very severe Parkinson's syndrome, because it does affect your dopamine release, makes dopamine more available, so it's very helpful in managing mild cases of Parkinson's disease. And it is now also being used for managing restless leg syndrome. There are people that have all this jitteriness when they go to sleep. They'll have muscle spasms in their legs. It's called restless leg syndrome. And amantadine has been shown to be very helpful in that situation. Amantadine, well, the mechanism of action is what we just said. It's an M2 protein channel inhibitor. so by doing that, it prevents the virus from fusing with the host cell, and it also inhibits uncoding. Okay? So it can inhibit fusion, it can inhibit uncoding of the virus. If you give it at the regular dosage, which is usually 200 milligrams, per day, and we use it for 3 to 5 days, it is safe. Okay? But if you go a little above that, it produces some severe CNS effects. So we always say that if a patient has epilepsy or a history of epilepsy, they are never to be given amantadine. Okay? It can cause hallucinations, it can cause confusions and convulsions, it can cause depression, so it produces a lot of CNS-related adverse effects. And then, of course, some non-specific GI adverse effects. So that's the problem with amantadine. Okay? And amantadine is an analog of amantadine, but it's a product that is far less toxic than amantadine. Okay? It does not give you all that CNS adverse effects that you see with amantadine. And amantadine is still used in certain institutions for prevention of the flu. It can prevent your flu A and flu B infection, but mostly flu A. And it's the same thing with amantadine. It will decrease entry, that is decrease fusion and entry, and then it will decrease uncoding of the virus. Aerodon is a member of that M2 proton channel inhibitors, but it, for some reason, never made it big in the US. So we can bring those out and take those out. All right. So we can go back up here and look at these agents that are called neuraminidase inhibitors. So oseltamivir, zanamivir, and peramivir, those three are neuraminidase inhibitors. And the representative agent there would be oseltamivir. Okay, that's the one that is most often used today. Zanamivir came before oseltamivir, but because you have to inhale all that powder, because zanamivir comes in packets of little 5-gram powders that you have to inhale. So it was 2 bodies on. And it caused a lot of pulmonary side effects also. Anyway, so oseltamivir is the one that is mostly used today. So if we look at oseltamivir or the Tamiflu, okay, we know that it is a prodrug. Okay. It is an ethyl ester derivative of your oseltamivir carboxylate. So So the active ingredient is actually the oseltamivir carboxylate. And like we said, it is an ethyl ester derivative. Okay. And the mechanism of action is to inhibit that neuraminidase. All right. If you look at your swine flu, or you've heard of avian flu, you always hear them say H1N1, H5N1. The N there actually stands for neuraminidase. The H is hematocrit. So basically, this so-called H1N1 is representing the antigenic variations of that flu virus. So that's why every year they have to know which one is around before the vaccine is made, because it has to take into account what the antigenic variation is for that year. Okay. So that enzyme neuraminidase is involved in three major things with respect to the activity of that virus. It is involved in aggregation of the virus. Aggregation is one means by which viruses protect themselves from the immune system of the host. Okay, so it is involved in that. It is involved in replication of the virus. Okay, so replication, aggregation, and release, which was the third phase that we mentioned earlier. So aggregation, replication, and release of the virus is controlled by, or are controlled by your neuraminidase. So if you can inhibit neuraminidase, you can actually inhibit the viability of that virus. So in terms of the mechanism of action, that's how your oseltamivir works, or your Tamiflu. Okay. And if we look at the ADMA for the drug, that is for oseltamivir, we know that it is administered on a PO basis, and you can use it either POQD if you want to use it prophylactically, but it can be given on a BID basis if you want to use it for treatment. Okay. So if it's for treatment, it has to be administered no more than 48 hours after the onset of symptoms of the flu. Beyond that, it's not going to be effective. Okay. So you have a 2-day window for this drug to be effective. And when you give it orally, food tends to increase its tolerability. In other words, you get less GI adverse effects from your Tamiflu if you administer it with food. And if we look at the distribution, maybe we look at the half-life. The parent compound has a half-life of about 1 to 3 hours. But the carboxylate, which is the active product, has a half-life of 6 to 10 hours. And that's why you can actually give it on a BID basis. It's because of that active moiety that it has a half-life of 6 to 10 hours. If you look at the plasma protein binding for the parent compound, it is about 42%, but for the carboxylate, it's only about 3%. And that's why you can get CNS adverse effects from your Tamiflu or from your oseltamivir. Okay. And in terms of metabolism, it is metabolized by esterases, not by your cytochrome P450 system. Okay. It is metabolized by those esterases. And excretion is mostly renal. In fact, the carboxylate is 99% excreted through the renal system. So that is the active moiety, right? It's about 99% through the renal system. Okay. So that's for the ADME of that drug. The indication is what we mentioned. It can be used to prevent the occurrence of the flu, and it can also be used for the treatment. The dosage that you use will depend on the weight, the body weight of the person. Okay. You can see the 30 milligrams and the 45 and then the 60 and the 75 milligrams of your oseltamivir. And you go by saying if the person, if the patient is less than 15, kilograms in terms of their body weight, they should be getting 30 milligrams of oseltamivir. Okay. And if it's from 16 to 23 kilograms, that will be 45. Okay. And then, of course, if they go from 24 all the way to 40 kilograms, you use 60 milligrams, and then greater than 40, which is usually where the adults will be, you'll be using 75 milligrams. So that's how you dose oseltamivir. So once you know the weight, you know how much they should get, and then you find out whether you are using it prophylactically or for treatment. If it's for treatment, that's the dose you give on a BID basis. If it's for prophylaxis, it will just be on a PED basis. But in all of those situations, it must be, that is treatment situations, it must be given within 48 hours of the onset of symptoms of the flu. The adverse effects that you can see with your oseltamivir, you can see an increase, unfortunately, in ear, nose, and throat infections. Okay. And you can see an increase also in the incidence of sinusitis. Okay. And then you have your non-specific GI adverse effects, nausea, vomiting, diarrhea. It's mostly the nausea and the diarrhea that people exhibit. Okay. And then you have the pulmonary adverse effects, which would be things like cough. Okay. So you can see cough, you can see bronchospasm with that agent, and you can see inflammation, resulting from that. And then in terms of the central nervous system adverse effects, you can get insomnia in particular. Okay. Insomnia, and sometimes people can feel a little lightheaded or drowsy sometimes. But insomnia is a major manifestation of the adverse effects on the CNS. Okay. So those are your neuraminidase inhibitors using oseltamivir as the representative agent. This peramivir, that is administered intravenously. It's administered intravenously. And you just give 600 milligrams IV, and it's usually just once for the management of the flu. But it's the same thing, it has to be administered within that 48-hour window, for it to be effective. Now, baloxavir is not a neuraminidase inhibitor. It is even not an early phase agent. We put it in here mainly because it is used just for the flu. Okay. Since we're discussing the flu with the neuraminidase inhibitors, we can mention baloxavir, that's your inhibitor of polymerase acidic protein. Polymerase acidic protein. Basically, what it does is it inhibits the endonuclease activity of your polymerase acidic protein. And when it does that, it will inhibit the replication of the genome of that patient. So you will not get the translation, the transcription and then translation of the gene of that virus. So that's how baloxavir works. It is administered also just based on weight. Okay. It is given orally, and the demarcation is 40 kilograms of body weight. If the patient is 40 and below, you give them 40 milligrams. It's a one-time dose. Okay. If it's 40 kilograms and below, they're getting 40 milligrams of your baloxavir. And if they are above 40, they get 80 milligrams. Okay. So that's the demarcation, is the 40 kilograms. That's another drug that is not metabolized by your cytochrome P450 system. It is mainly metabolized by UDP, that is uridine diphosphate glucuronidase transferase. That's what metabolizes it. Majorly, that's the major metabolic pathway. To a smaller extent, you can see it being metabolized by your 3A4. Okay. But the large or the main pathway for biotransformation is that. The drug is, of course, highly plasma protein bound, 92 to 93% plasma protein bound, and it has a half-life of 79.1 hours. So it's long-acting, that's why you can just give it without long-time dosage. And the adverse effects you get from baloxavir, it can give you headaches, it can give you some nausea and diarrhea, and then pharyngitis. Those are the main adverse effects. So headache, nausea, diarrhea, and pharyngitis. With that baloxavir. All right. For Maraviroc, when HIV first started, 1981, of course, nothing like Maraviroc was available, and people used to think, well, we all thought that the HIV just needed to bind to that CD4 receptor on the membrane. So the virus is coming like this, HIV, and this will be the CD4. But then, of course, it was found out later that it can also bind to CD8. Okay? And we used to think it's only your T cells that will bind to T alpha cells. But then it became known that it can bind to macrophages. Okay. So you have to change the definition of the HIV infectivity, which basically led to the classification of HIV into two groups. The HIV that is macrophage tropic, or what you call M-tropic HIV. Okay, and then of course the old one, which was T-tropic, that is the one that is attracted to T cells versus the one that is attracted to macrophages. Okay, so that was that. And then somebody went to Congo, went to Dr. C, that's DRC, okay. The Democratic Republic of the Congo, okay. And it was found that some people there were actually co-mingling with people that had AIDS, but they never got AIDS. So what was protecting them? That was what led to the discovery that HIV cannot, that is, the virus, cannot produce AIDS in you if it only binds to CD4. It's not stable enough. It has to bind to a co-receptor. Okay. So it's like a two-pronged thing. If it only binds to CD4 or CD8, this other arm of it will render it useless. So it has to bind to the CD4 and then to the co-receptor for it to be stable enough to fuse with the membrane and then get inside the cell. Okay. And what was that co-receptor that's needed for HIV infection? It was found to be chemokines. That is, chemokine receptors. Chemokines are pro-inflammatory proteins that we have circulating in the bloodstream anyway. Okay. MIP alpha, MIP beta, rantes, those are all examples of chemokines. And so if you block the co-receptor, then you can prevent AIDS from happening. So in those patients that were not getting AIDS, it was because they were producing a lot of the chemokines that were blocking those co-receptor sites. And the chemokines then were divided into 4 families. You have the CC family, then you have the XC, and then you have CXC, okay. And that was the third one. And then you have the CX3C. So those were the 4 families of your chemokine receptors, or the chemokines themselves. Okay. And then, of course, a drug was developed that can occupy that co-receptor or site. And the first drug that was developed to do that was Celsentry or Maraviroc. Maraviroc, if you look at the mechanism of action, it is a CCR5 inhibitor. Okay. And people always think that CCR5 means, co-chemokine receptor 5. No, it doesn't mean that. Okay? It just means, like we said, finally, the drug interacts with this particular member of the 4 families of your chemokines. Okay? So, Maraviroc works by inhibiting, that is by blocking that CCR5. And that way the HIV, the virus, could not be stable in terms of its attachment to the cell. And so for your Maraviroc, we know the mechanism of action. In terms of its ADME, we know the drug is administered orally. You give 300 milligrams POBID. We That's the dosage for that drug. And if you look at its half-life, the half-life of the drug is 14 to 18 hours. And it has a plasma protein binding capacity of about 76%. In terms of its metabolism, it is biotransformed by your 3A4. It undergoes and dealkylation. And in terms of its excretion, it goes out primarily through the feces. About 76% of it will go out through the feces, about 20% will go out through the renal system. Okay. So that's how it works, and that's its ADME. Indications. One, it will be used or it can be used for the management of AIDS. Okay. And it's also used for something else. It can be used to prevent the graft versus host disease. Okay. In patients that are undergoing transplantation, like the bone marrow transplantation and all that. So Antivirals helps to prevent the graft versus host disease or disorder. Yeah. So those are its two indications. And in terms of its adverse effects, number one, since it's administered orally, you can expect some GI adverse effects from that drug, and you do get it. Number two, it can affect the liver to a certain extent, so it can be hepatotoxic. Okay. And three, some skin reactions, rash, pruritus, things like that, itching. So it can produce all of those. Four, it seems to have a bad effect on the cardiovascular system. It can give you myocardial infarction, MI, and it can also give you orthostatic hypotension, okay, or what you sometimes call postural hypotension. So it can give you that. And you see an increase in upper respiratory tract infections when that drug is used. And then it can also cause allergic reactions in certain individuals. Okay. To a minor extent, it can cause a little bit of dizziness. So those are the adverse effects that one can get from your Antivirals. Take that out. And along the lines of Antivirals, you have this drug Ibalizumab. Ibalizumab is also used for AIDS. It also works by inhibiting CCR5, okay, CCR5, but in addition to CCR5, it can inhibit CXCR4, the other class of your chemokines, so CXC receptor 4. So ibalizumab works at those two receptors and thereby inhibit the entry of HIV into the host cell. And mogamulizumab, the mogamulizumab is not used as an antiviral agent. It was originally manufactured for that, but it was then found to be more effective in the treatment of CTCL. Yeah. And that is cutaneous, that is skin, T-cell lymphoma, which is a type of cancer. Mogamulizumab tends to work at the CCR4. Okay? So it inhibits CCR4 and it is effective in managing CTCL, not really used for viral infections anymore. And Fortitide, which is available as Fusion. That is its brand name. This is a drug that was just totally synthesized because it is made up of 36 amino acids, just totally synthesized, just 36 amino acids being brought together. And how it works. It binds to HR1. Okay. In your GP41, that envelope of glycoprotein. HR stands for heptide repeat. Okay, that is a structural motif. It's a structural motif that is characterized by a repetition of 7 amino acids, in that order. That's why you say hep. Hep refers to 7. So you see 7 amino acids repeating constantly on that envelope protein. And so that's what your fusion would inhibit. So if you inhibit that, then of course the virus will now be able to attach to the host cell membrane. And then you get complete effect from that drug. How it is administered? Subcutaneously. You give 90 milligrams of fusion subcutaneously usually on a BID basis. Okay? And that's how it is used. It has a half-life of about 3.8 hours. You know, the plasma protein binding is right around 91. So, the lower end is 79.1, and it can go all the way to like 90. When we take the 79.1 as the plasma protein binding capacity or capability of fusion. Metabolism, it just gets broken down to its constituent amino acids. So we're not talking about 3A4 or anything. Just these amino acids we just disintegrate, we just fall apart. That's the metabolism. And of course, excretion is primarily renal once those amino acids are separated. So that's its ADN. Indication would be just for the management of your viral infections, particularly it can be used for HIV, which is what it was originally created for. Adverse effects. The number one adverse effect of fusion that one should keep in mind is injection site reaction. The injection site reaction adverse effect can be bad enough to warrant the discontinuation of that drug. So it can be really severe. Two, because you're putting all these new amino acids into somebody, you know, it's like injecting protein into somebody, you can expect hypersensitivity reactions. And that's the second adverse effect, hypersensitivity reactions. And the third one that is also serious when it happens is pneumonia. So we have injection site reaction, you have hypersensitivity reactions, and then you have pneumonia. Those are the adverse effects of your fusion. Okay. And the name suggests the mechanism or the effect of the mechanism of action. It would inhibit the fusion of that virus with the host membrane. That's how it is. So that's the early stages. Then if we go to the synthetic events, for the synthetic events, we can start off with drugs that are purines. Okay. Because if you look at your DNA, RNA, and all that, you're talking about pyrimidine bases versus purine bases, or pyrimidine nucleosides versus purine nucleosides. So these ones are the purines. And the agent that we will discuss primarily is cyclovir. Okay. What we'll do, we'll just take 1 minute to nullify all these other ones by just looking at their indications. So next time we'll look at the pharmacology of, cyclovir. IRA, which is your arabinoside, adenine. So from that, you know that it is a purine, adenine. Okay. That drug can be given IV, and it can be given topically. We give it topically or thermically for eye infections caused by HSV1. Okay. You give it IV to treat HSV-induced meningitis. Okay. It could be meningitis and it could also be encephalitis. So meningoencephalitis. And it has been life-saving in that situation. You know, we give it IV. 50 milligrams per kilogram IV is what we use for IRA. And that's not to be confused with IRA C, arabinocyte cytosine, which will be a pyrimidine. Okay? Adenine is a purine, cytosine is a pyrimidine. Okay? But we'll mention that when we get to the pyrimidines. Okay? Valgacyclovir, its pharmacology will be just like your cyclovir, but primarily it is used now for cold sores. You give 2 grams once. It can knock off that cold sore. Ganciclovir and valganciclovir are primarily used for CMV retinitis. Okay. So cytomegalovirus induced retinitis. That's what those 2 agents are mainly used for. Penciclovir can be used for your cold sores when given topically, because you have an ointment, that is called Dinavir, that you can use for cold sores. But that drug can also be administered intravenously. And when it's given intravenously, you use it for genital herpes. And famciclovir is actually related to penciclovir, is prodrugs, if you will. And famciclovir can be used for genital herpes. That's what it is used for mostly. And it can be administered orally. Okay. So you have your pill for famciclovir. And ribavirin is the most versatile, if you will, out of all those purine derivatives, because
so the peel version of famciclovir is for genital herpes,
right?
And for panciclovir is the IV.
Yeah, it's the IV of panciclovir.
Okay.
Yeah, the topical is just for cold sores. For panciclovir, that's Dinavir. Ribavirin you can use for hepatitis B, hepatitis C. You can use it for flu A, flu B. You can use it even for the treatment of dengue fever. It's helpful in that. You can use it for SARS. That severe acute respiratory syndrome. So it is a very versatile agent. And we mentioned earlier that it is also effective in RSV, respiratory syncytial virus infection. So that's your ribavirin. It is sometimes even used for the management of chickenpox and shingles if you don't have any better drug that you want to use. So it's a very versatile agent. And if you break this down, See, it's star ribavirin. So that is an analog of ribavirin that is believed to be less toxic than your ribavirin. And so next time we'll look at the pharmacology of sacovir, and then we'll go to the evidence. Questions?
So do you advise somebody going to DRC to take Maraviroc before going?
No. Because the thing doesn't fly in the air. So it will not be necessary. Okay. Any other questions? Okay. So who are the 5 people that made 94 and above? Class average was very high.
Come on. 80%?
What was the percentage?
Yes, sir.
Almost 80.